Давайте начинать, пожалуйста.
Let us start. Please, can you close the door, if it's okay for you? If you need simultaneous interpretation, because today we'll have a presentation in English, so please take the necessary equipment. If you you have time to do this right now. Let us start, dear friends. Once again, good afternoon. I would like to welcome you all at the 8th Assembly Health in Moscow. And health is essential and extremely important, the biggest value which we all have. And you all know the value of these words. In modern world, now it's quite fashionable to do sports, to go to do screening, to do everything possible to prevent any diseases. But sometimes there can be situations when life can be split before and after. This can be traumas, accidents, and falls, a lot of things, and wars maybe. There are many situations which can lead to very difficult traumas. Statistics say mostly kids are subject to traumas, and also adolescents and youngsters. But today, mostly we'll focus on kids, and we'll speak about spinal traumas, speaking about Russia and Moscow, the pioneer in this issues. Is scientific university of medical rehabilitation and emergency services. The scientists of this institute set goals to do everything possible to make a kid good life. Any disease is very difficult, and if we speak about spinal trauma, spinal injuries, this is a very difficult experience, because behind these kids there are siblings, grandmothers, grandfathers, parents, and they all focus on these kids who need help. In this institute we developed unique programs, and today Svetlana Albertovna Valyulina will speak about them. And I want to say also that the experience of Traumatology Institute is copied by other healthcare clinics and hospitals of Russia, and also the institutes of abroad, because we have a lot of experience, clinical trials, and this all information is published around the globe. And one of such publications was noticed in Sweden. This is Karolinska Institute of Stockholm. In the city of Sundsvall. These people connected us. In May we'll have also a delegation from Sweden, and today we have a speaker from this Institute of Stockholm, consultant, and today we'll speak about spinal injuries. Pediatric spinal injury. We have only 1 hour, 23 minutes. This is quite a tough schedule, and if we have still some time left, we'll ask questions. But now I would like to introduce our two main speakers of today's session. Maybe it's not even the session. This is mostly Matt talk even. Marika Augutis, Sweden. She is a physiotherapist. She works in rehabilitation. She has worked for a long time with patients of spinal injury, with adults and kids. Also, she had a thesis, PhD thesis, and the name of this thesis was The Trauma of Spinal Injury of Kids. Now she works as a scientific consultant in Suzdal. This is also the branch of Karolinska Institute in Stockholm. She also is a consultant in a Swedish hospital in Lichinga, and since '82 she's an active member of non-profit organization Active Rehabilitation. They organize different sports camps for rehabilitation. They expand possibilities for people with disabilities. And the activities of this organization is not restricted only by Sweden. This project also works in Eastern Europe. Marika also is the member of International Association on Spinal Injuries and association which is called STEEL association. These are specialists who work in the area of rehabilitation, social activities. They work with pediatric traumas. Marika is the author of 13 publications, and today's her topic is organization of rehabilitation help for adults and kids with spinal injury in Sweden and other countries of Europe. This is our first speaker. So now, please, I would like to introduce our second speaker. Maybe of you know her, Svetlana Volyublina. She is a professor. She also is a chief specialist in medical rehabilitation and spa treatment at the Moscow Department of Health. And of course, she is a chief ideologist and organizer at the Institute of Modern Rehabilitation Department, which is the best as minimum in Russia. And this about the children with very heavy traumas. Also, Svetlana is the head of the foundation, which was created at this institute, the foundation of Rashalia, pediatric doctor Rashalia. Also, they cooperate with Paralympic Committee. Svetlana will speak about this. And kids who go to this institute in time, they receive a full complex of treatment and rehabilitation. And then some kids then have a good sports career. These are our two main speakers. Now let's start. I would like to give the floor to Marika. Marika, are you ready? Please, Marika, you're welcome. Once again, if you need interpretation, because we have real-time interpretation, please take your equipment.
Yeah. Okay. Thank you for inviting me here. I'm very thrilled and excited to be in Moscow. I've never been in Russia before, so it's really big for me to be here. I will talk about the need of international collaboration in the field of pediatric spinal cord injury. And why is this important? It's important because in many countries, pediatric spinal cord injury is a rare injury, and it's not the same as spinal cord injury in adults. They have different complications, and it affects the child in different way than adults, and we still don't know so much about treatment, rehabilitation, and also how to prevent these injuries. And there's still a lot of knowledge gaps in the rehabilitation of the children, and therefore we have to work together to improve the lives of the children. I'm also going to talk a little about epidemiology, how it looks in Sweden and in the world, and a little about rehabilitation, what is consensus, what is important, and also a little from my research that I did interviews with adolescents or persons who were adolescents at the time of the injury and what they thought was most important for their rehabilitation. I will also talk about the importance to meet other persons with a spinal cord injury. We call it peer support or role models. That's 2 words for it. And then a little about these sports camps. Because in Sweden, the rehabilitation for adults has been very scattered. And therefore, this patient organization started to have camps for a week for newly injured, but also other persons. And I have been a member of this, as you told before. And so in the end, I will talk a little about that too. Yes, I was physiotherapy at a mid-sized hospital in Sweden, and then came Emily. Emily was at that time 6 years old, and she sustained injury C6, C7 from myelitis. And because of my work in this organization, I had met a lot of people with spinal cord injury. And so it was not so, but very few children, and I knew that it was rare. I tried to find another family with a child that could support this family, but it was impossible. And the pediatrician and me, we searched for a lot of information. And this was in the beginning of the 90s, so it was internet was not so easy. But we found a book from these persons. It's Professor Vogel from Chicago, Cassie Sibracki, she's a psychologist, and Randall Betts, he's from Philadelphia, and MJ Mulcahy, she's an occupational therapist. And they wrote a book. On the picture here is the 2nd edition, but it was a comprehensive book about management of spinal cord injury, and we came in contact with those. And they have worked the whole, very much, so almost in the 90s, all research came from the United States. And we still collaborate. But I got very interested in this, so I did my thesis, I think or my dissertation on pediatric spinal cord injury. And I could conclude that it's a rare injury. In Sweden, we had very scattered care. We had no special rehabilitation for kids or spinal cord injury because they are so rare. And we also saw that we needed more international collaboration. And now it has changed a little because in Linköping at the University Hospital, there's a doctor, Per Ertsgaard. He's going to see all the children in Sweden. We are trying to centralize the care, at least the follow-up. And Sweden is a long country, so we probably use a lot of video consultations and things like that to keep in contact with the home hospitals. And we also have started to have more collaboration with the Nordic countries and also international collaboration. And that's we heard about Svetlana's work in Moscow, and we got very interested because we need to meet more children to learn more. And I think we could be a very good way to collaborate. We need doctors to educate them more and so on, to see more children. Yeah, I found that in Sweden it's 2.4 children per million children per year under the age of 16 that sustains a traumatic injury. Emily, that I told you about, she had a myelitis that we call non-traumatic injuries. For non-traumatics, we have no idea how many they are, but we think they are maybe the double size of the traumatic injuries. Anyway, it was a high mortality. It was because many died at the scene of the accident, and that's because it was mainly traffic accidents in Sweden. And if you count this, at that time it was 1.6 million children a year in Sweden. It should be not more than 3 to 4 children every year that sustained a traumatic injury, and that's very good. But it's also caused problems because the knowledge about pediatric spinal cord injury is quite unknown in the usual hospital. We had very few fall accidents, almost none. And we had, for adolescents older than 10, they were injured by sports as much as traffic because of this risk behavior in adolescence. They are more prone to have sport accidents, and Peter New, he's an Australian physician, and he just recently did a systematic review over the articles that's written about pediatric spinal cord injury, and he could conclude that it's very rare. There's not many articles, and many are not, even if they are peer-reviewed, they are not so good quality that you can't count what the incidents are. But you could see that most accidents come from traffic or transportation, he calls it, and then comes falls and sport recreation injuries. He did some median incidence, and like Western Europe, it's 3.3 children per million children, but it varies a lot from 0.9, you can see, to 27 children. And that's why in Southern Europe, like Portugal, Greece, and Italy, there's much more traffic accidents than we have in Sweden or the Northern Europe. North America had 13.2 children, and Australia, New Zealand, 9.9 children. But it's these figures are quite unsure because they different in cut-off ages. Sometimes children who died at the scene of the accidents are included or not. And it's a sort of, there's no common description in the articles. That makes it difficult. It just, in November, it came an article from India, because most of the articles before, they come from high-income countries, but you can't say that about India, but they had 204 children in 13 years at just one center in New Delhi, and there were falls very common. But they couldn't say how many children they were at risk for a spinal cord, so the incidence is not, they couldn't count that. But they could show that injury increases a lot with age, and that's what I told before about the teenagers who risks a lot. For non-traumatic injuries, it's even worse. There's very few articles. And Peter New, he excluded spina bifida. It's just sustained injuries, not congenital injuries. And then you can see that tumors are the most common cause, and then inflammatory or autoimmune cause, but also there are vascular causes for this. It's important to know the incidence, because we have to know how many the children are, and of course how they injured, to be able to prevent the injuries. And when it's rare in a country, it's not so easy to know what really, you have to pool all groups to see this problem even more, what's preventable. And it's also important to know it, because otherwise you can't plan care and rehabilitation. And then with the spinal cord injury, it's a complex injury, and there's risk for secondary complications. And that's also we have to describe, and many of these secondary complications is preventable. So it's therefore it's important to improve the registration, to have uniform methods, and we need more publication about pediatric spinal cord injuries. There's 3 organizations, I will talk more about them, is ISCOS, Asia, and Steel Assembly, that are working for persons with spinal cord injury. ISCOS is the International Spinal Cord Society. It works in 87 countries in the world. It's open for all health professionals, but also consumers, they say. Consumers is persons with spinal cord injury themselves. They can be a member in this. And they work to improve the care for spinal cord injury. And they work closely together with the American Spinal Injury Association, called Asia. They have the same goals actually, but it's mostly North Americans, Canada and United States who are members, but they also have international members. And they have worked for many years now to find out how to describe a spinal cord injury, and they do it through this International Standards for Neurological Classification, INSCI. And they want that if you publish, or you should use this kind of assessment for spinal cord injury. They have also worked with something called these are from their home pages. Because the injury affects so many areas, and then they have done data sets for every area, very few questions that should cover, and they have taken it from validated instruments and so on. For children, they have added items in many of these data sets, but they also there's 2 newly developed data sets for the pediatric population. It's for education and pediatric activity participation. And that's like a questionnaire that's used in clinic and also for research. On these home pages, you don't have to be a member to go into this home page. They have modules for healthcare professionals, but also for patients themselves, or persons with spinal cord injury, or nurses, or occupational therapists, and so on. That's from eLearn, from SIA.org. It's coming a module now also about pediatric spinal cord injury. For Asia, also have a very structured course about how to assess with this neurological assessment that I talked about. And it doesn't cost anything to go in. It's just if you want a certificate, I think it was. Yes, Steel Assembly. That's a new organization, international organization. It's from the Shriners hospitals with the persons I told you about before, but they will also try to promote the best care for children and adolescents with spinal cord injury across the globe. PEPSCI, that's a collaboration between researchers and clinical persons in Europe, but also in the United States. And we made a questionnaire to send to children and also their caregivers or parents to ask them what are the most important topics. What do they really would like to improve in care and for research. And these questionnaires are sent out, and here from Russia, Professor Svetlana is from the Pediatric Surgery and Trauma and Rehabilitation Department in Moscow are also participating in this network. Yes, goals of rehabilitation. The consensus is that in a short perspective, it's important to come home as soon as possible to their normal life. And long-term perspective is to have a satisfying and productive adult life as their peers. And to be able to do that, we must optimize their function and also prevent these complications. Family-centered care is very important to involve the parents in the care. The strength and the needs of all family members should be considered, and don't forget the siblings, and also the child's friends is an important part of the way to think rehabilitation for kids. It can look like this. It's just an example. I mean, you work in team, multi-professional teams. Someone is more close and someone is just going in sometimes, but the child is in the center. But the family and the siblings are also members of the team. And I think friends are very important from my research, and also this peer support to meet other persons with spinal cord injury. In Sweden, we try to employ persons if they have education that could be useful to employ them in the rehabilitation, so the newly injured people can see that you can work as well as before. So it's not just a person coming with an injury to talk to another. It's also to see that people are working, they are driving a car, they are out in the public and doing things. Yeah, I did interviews with persons who sustained a spinal cord injury, and they all said that the parents were very important. They were important as advocates towards the staff. They were important as supporters, to say, oh, you are very good, hiya, hiya. And, but they were also important as punching bags. And punching bags that some of the adolescents, they didn't dare to show their anger and frustration over the injury, so they took all the things on their parents, and they got really unfriendly with their parents. And I think this is important, is to inform the parents that this is an important role they have, because it will pass. But during the rehabilitation time, they will fight a lot with their teenagers. This is teenagers. They said that the friends were very important. And one guy said, many times I felt that I just wanted to stay at home but the friends more or less carried and dragged me and the wheelchair out of the house. This, to have my friends around, was probably what made me come back again. They also wanted to have well-defined, concrete goals that should be understandable. They wanted to have checklists so they could see that they made improvements. They wanted information, not just through their parents. They wanted to have their own information. And role models and peer support was important because they helped them to regain a new identity, but also to give them a perspective of the future, that you can have a family, you can drive a car, you can have a job and so on, to get more positive view of than maybe the hospital. Especially if the injury is rare, the staff are not so aware of what's happening after. So I think it's so important for them to meet role models. And yeah, and then camps. It's a non-profit organization in Sweden since '87. And we have also spread this to Norway and to Greece, and we have been to Ukraine and Belarus and to Lithuania, and in Africa also in many countries. And these camps, they are led by people in wheelchairs themselves with spinal cord injury. So it's a lot of peer-to-peer learning, like the picture up, and that's a guy with a tetraplegic who are teaching a girl with a tetraplegic how to come from the bed to the wheelchair. We are trying to focus on opportunities rather than all the problems. Look at the possibilities. And I have, in Belarus, they have had this organization since '96, and they have 2,000 members. And in this video I will show you, it's mostly adults, but they also adolescents can participate. And in Sweden and in Poland also has a very big organization like this. They have special pediatric camps. I have no video of that, but it's good if they can be connected with the adult camps, because then the parents and the kids will see the older ones. And I think also that we use sports as a continuum of rehabilitation. It's something that everyone can do after the camp at home, for a table tennis or go weightlifting. So they learn the skills of that, so they can go into a regular organization, because sometimes there's no other person with spinal cord injury in their hometown, but with sports they can continue. So please, can you show the video? It's in Russian.
Лагерь активной реабилитации – это эффективная реабилитация. Она предназначена для людей, которые волей случая стали пользоваться инвалидной коляской, причем недавно. В Беларуси это развивается уже более 20 лет. Каждый день у нас проходит 3 тренировки: стрельба из лука, плавание, общефизическая подготовка, настольный теннис, аэробика. И одна тренировка обязательная по технике езды на коляске активного типа. Обучение проходит по принципу равный равному.
Опа! И заехали.
Это очень эффективно, потому что когда ты на равных, ты не можешь сказать, что я не могу. И вообще в лагере такого слова просто не существует.
Правильно.
На этом лагере люди получают базовые знания.
In this camp, people received basic knowledge so that they could integrate into the society.
So, spasiba, thank you. Tack så mycket.
Спасибо большое, Марика.
Thank you very much, Marika. Friends, now I would like to say a few words. Marika spoke about support. Support of relatives is very important. I have also a special child, but my child does not have this trauma. He has some other condition, but we are active. We visit all events. Family, mothers, fathers, grandmothers, and grandfathers, of course, they are always with us. But when there are also friends, I think this is extremely important and valuable for such patients. And if you have also kids with disabilities or your friends have such children, please try to communicate with each other, because it's very important. Communication is important, and socializing is important, very, very important. Now let's proceed. We'll now speak about medical aspects of such traumas. I would like to give the floor to the Professor Svetlana Valiulina. Good afternoon, dear friends. I'm happy to see you here. We now are participating in such so-called Med Talk. It's very useful to share our experience, our opinions. It's so interesting to know how the countries exchange their information. Recently, it was considered that if a child or adolescent receives such a trauma, he should always be stricken to bed or should be stricken to wheelchair. But life shows it's not like this. These patients also can have life, maybe different, but still it also can be interesting, beautiful, and good. Our patients can marry, they do sports, they give birth to children, and they also succeed in professions, in work. But of course, we should work at this. Now, a few words about relevancy of this work. 40 million of people in the world annually get this SCI. And mostly these are young men till 20 years. And if we speak about children, these are mostly school kids and adolescents. So 5% kids. America has already mentioned how they gathered information about these patients. Data. I can say the same. In Russia, so we practically did not conduct epidemiological research on SCI, and we also gathered this information. We are the Institute of Emergency Services and Rehabilitation. We have the flow of such kids, and we have a lot of such kids, maybe more than in Sweden and in Germany, in England, and with Angelina, she is also here. She is the head of our international department. Visited also Moldoville Hospital in Great Britain, where Paralympic Games were changed. And Gottman, who then moved to England, created this rehabilitation system for patients with spinal injuries. Then I visited Botman Center in Barcelona, and it's amazing. I visited the Center of Paraplegia in Sweden, and I could see there also this help network starting from aviation transportation, ending up with discharge, hospital discharge, only when patients really can do a lot of things themselves. When patients can already sit in the car and you know, do everything, all manipulations regarding wheelchair, and this is amazing. This is awesome, and we also should do this work in Russia. Patients who receive such injuries, spinal injuries, such patients have structural functional changes, spinal periphery system. And also we should work at this. Can we work at this? And how can we cope with it? Now, life shows, yes, we can work with it. In our institute annually, we have more than 7,000 children with different types of trauma, more than 300 children with spinal injuries, and 14% out of them can have also traumas of spinal cord. And this is quite a lot. This is 30-40 patients per year, and I will show them. Unfortunately, I don't have epidemiological data in Russia, and we started also to collect this data at our institute. What did we see? Marika has mentioned that in Sweden and in other countries, these are mostly car accidents, but among our patients, these are also 42%, or you know. So injuries of spinal cord. Also babies, there were cases when babies were sitting in cars in their small chairs, but still during these car accidents they had a lot of traumas of abdominal area, and also they had injuries of spine. And accidents 30% in Russia. This is the trauma. Maybe you heard my presentations. I also speak about this household traumas also. I can say that we have children not only from Moscow at our institute. We have a lot of children from different regions of Russia, also from abroad. Sports traumas, 15% out of children. And among them, we have several children fighters. And when they received these traumas, when they had fractures in spine, and something happened, and some maneuvers in sports were forbidden. Thanks and other things. Got also suicides, shootings. And shootings are also here, also in this structure. This is the structure, so also the injuries in cervical, so then breast injuries 39%, lumbar section, this is 19%, multi-level 7%. And we have such a table. Here you can see the levels of damage of spinal cord. Here you can see that if damages has the level C5, I don't remember, maybe these are 70s or 80s when we introduced this table, and the physicians said at that time that such patients can't do anything themselves. He can't eat himself, he can't dress himself, he can't go to a toilet himself, even turn. He can't do anything with a level C6. Maybe he can do something. Maybe he can eat himself a little bit, turn in his bed, and maybe he can use a wheelchair. But we managed to disagree with this data, and our research showed this. But before I will speak about my experience, I would like to show you this confirmation of this table. This is the boy. Unfortunately, this boy got to us only in 3 years after the trauma. And I just want to show you this. The boy had good surgery, and then a physician said to his mother he will never walk. He has been lying for 3 years, and what he has now. And he went to us with a horrible bad sore. And when we saw this, so this is C6, our team cried when we saw it. And or maybe this child. I cannot click. This child also got to us only after 3 years after his trauma. Again, surgery was great, and then again they put him in the position of the frog, and he was lying in the bed, developing complications. So the bladder practically was ruined. The boy has astonishing cognitive abilities. And now I will speak about our kids, our control group. So we had 5 years, 2014-2019. We had different levels of traumas, 154 kids, C4, C2, also C5, C7 levels of traumas. You can see this in front of your eyes. And different types, concussion, then skivora, and blocks, falls, and different traumas. Also, in the process of our work, we could see that if diagnosis is right and timely, if the surgery is done quickly and very well, and if intense rehabilitation started quickly in time, so in this case we can great possibilities to restore such patients. We have a lot of opportunities for recovery, for their recovery. So you can see these kids with heavy traumas in pictures. In our work, we developed, we focused on 3 stages of approaches. So the first stage, reanimation, emergency therapy. The second, rehabilitation, beds, and the third stage, out-of-patient rehabilitation. But then, so we could see that within the first stage, there are also some phases. And we define different phases, pre-post surgical periods. Usually this happens in intense care department. And the second, adaptation to moving deficit, also intense therapy, and then training. This is already specialized department. And for this, for each stage, we should have all their own goals, rehabilitation teams, and means to help these patients. I don't want to speak a lot about methods and means how to recover these patients. We speak a lot about it. Our ideologist of our multidisciplinary team is Irina Novoselova. Unfortunately, she is not here today. But in May, we'll have our school with the participation of our dear friends from Sweden. And we, of course, will discuss this in details. And also will consult patients. Also, we decided a lot of tasks, and we did this step by step. Marika also has mentioned this. These patients develop secondary complications very quickly, immediately, practically. So the first, our goal is prevention of the secondary complications. We should train parents quickly how to take care of these children. Also, orthopedic correction. And making all conditions to restore children. This spontaneous recovery is very important. It's very active in a child's organism within first 3 months. So we should invest a lot within these efforts in these 3 months. From 3 till 6 months it fades away a little bit, these activities, and then 6 months already. So what patients have when he has this traumas already for 6 months, nothing can be so it's difficult to change something already. I paid attention to this, that patients with very difficult SCIs, they are under control for the first 6 months. Then of course patients can get rehabilitation procedures, but the most focus is on this 6 months. Also, correction of metabolic disorders are important, training of parents, proper nutrition. And this is essential because this is trauma, and it's characterized by a horrible metabolic cascade which is launched from the moment of receiving of this trauma. So we should have good nutrition, proper nutrition, good metabolism, or we have some other problems. Also, bladder is important. And it's extremely important. And I showed you this picture of the boy who already had cystostome. 3 months of cystostome. This is atrophy of the bladder. But some people are afraid of catheterization. And recovery of natural movements, forming of compensatory movements is important. And Alexei Mocholov also will show us a small movie regarding this, a small video. This is our physiotherapist.
He is part of our rehabilitation team. Then the correction of post-traumatic emotional troubles is required. A new picture of the world needs to be developed. We also need to prepare parents, because they might think that a surgery will resolve everything. And we have here our medical psychologist who is working in a multidisciplinary team, who is working with the patient from the intensive care unit, and psychologist is the first one to contact parents. Another stage is adaptation to new physical particularities and training of parents. All of that allows us to develop the concept of the first stage of rehabilitation of children with spinal cord injury. And of course, we need pediatrician to assess the tolerance of the child to loads. We need him to help us to develop rehabilitation program for this particular child. This is the person who helps us to develop a nutrition program for this child. So here on the slide you can see the concept that we developed. For every stage we establish certain goals, and a team of experts is involved. And if the patient follows through all the stages of this rehabilitation program, the result will be quite good. Do I have some time left? Well, now I'd like to show you just in several slides what do we have. Look, for example, we have a cervical spine injury C1, C4, and this tetraplegia is accompanied not just troubles in moving the upper and lower limbs, but there are also breathing troubles because diaphragm is denerved as well as intercostal and abdominal muscles. Sometimes there are bulbar symptoms and vestibular dizziness. Remember the table that I was talking about? Did we mention C1 to C4 in this table? No, but still we are working with such children. We managed to stop artificial lung ventilation for them, so this is a breakthrough. We are also working with injuries at C5, C8 segment. In case of such injuries, there is the conductivity trouble, there is spastic paraparesis, there is trouble in sensitivity in hands, and so on. The forecast and the efficiency of rehabilitation of such patients can be determined by the possibility of flexing the elbow joint and by the possibility of radial extension of the palm. So here is what our patients are doing. Before, one could say that these children will just lie down and die, but you can see that these children can live. Yes, they are disabled, but they are adapted to this disability and can live with it. Here you can see C5 and C6. Remember these two boys. Here is our C5 boy. Remember what was in the table that I showed you. It is generally anticipated that he will never be able to eat and so on, but he is eating himself, he can use a mobile phone, he can do many things. Of course, his life is not absolutely full, but he is adapted to his deficit. And here you can see our boy with C6. He is practicing sports actively, he is living an interesting and full life. Next, thoracic injury. Again, there are many issues in case of such trauma. But what we have seen from the very beginning, if we did not receive the child directly, but only after another hospital, even if the trauma is at T5, T6 level, the child was tracheostomed and artificial lung ventilation was performed for long periods of time, and it took us a lot of efforts later to make them breathe normally. And here you can see our children. They are living full life, they practice sports, they marry, they have children. For example, we have a boy who first came to us when he was 16. They were driving a car with a friend. The friend was driving. The boy was not using seat belts, and he got a severe injury and got a severe thoracic injury. But still, he is now living a full life. And now L1, S1 segments or S2, S5 segments. In this case, the prospects for rehabilitation are better. And these children are even walking in our center. Here you can see these children. So we tried to challenge that table that was offered to us, and we can see already that even in case of C2 injury, we have children who can move in the bed, can sit in the bed, use the wheelchair, and then their skills are only developing. Here you can see it in the form of a picture. We tried to compare. In blue we have our data, and in red we have the initial data that was proposed by Dituno. So self-service skills appeared only at C6 levels, but we see that in our case the situation was much better. To conclude, I'd like to say that today we have started to develop a digital, physical, telemedicine-based rehabilitation. We received a grant to make this development. And we are now going to implement this system first for the patients with non-complicated compression fractures, and then for patients with spinal injury. Our goal is to create conditions for self-rehabilitation of children and adults with the use of smartphones or iPhones, using digital technologies to control how they perform the exercises. So the child will be able to receive doctor supervision, because what we see quite often is that we have exercise, we get good effect, but parents are afraid to go home, and they are coming to various centers one after another, but there is no system or logic in their actions. So what are our goals for the next stage? Quite often, if the parents do something not well, the child has to go back to hospital because he has over-exercised, for example. So to avoid that, we would like to develop this digital system. This is our team of children with spinal injury, and we have Mikhail Terentiev, our colleague here, and our children are living a full life. Thank you, Svetlana. On my behalf, I would like to say that I'm very pleased by the fact that the situation has improved. Several years ago, when parents knew what a good team you have, they tried to reach you and do everything that they could to get advice from your clinic. And what's good is that colleagues in other clinics are now having digital or telemedicine-based consultations with you, so your center can now help more people remotely. This is very good. Speaking about team, I'm happy to invite here Vladislav Mochalov. He is instructor for therapeutic exercise of the Department of Rehabilitation, and he is now preparing a thesis on rehabilitation of children with spinal cord injury. You will just say some words and then show a video, right? The video has already started. I would like to say a couple of words about our C5 patient. His spinal cord was completely damaged, and his possibilities now and his activities are much better. Here we can see the first month after the injury. We see active movement in shoulders, but the main thing that an expert in rehabilitation will consider is how well the patient can control shoulders. The patient is active. Here is an example of how he sat for the first time in wheelchair and how he was trying to mobilize himself. And it's only the second week after a severe injury. And here we can see him in 16 days. So he already develops the skill of movement. And this is C5 level. I would like to remind you of that. So 16 days after injury, even edema is still there, but still he has such a good level of activity. He is changing the position himself, which is one of the benchmarks among the skills that every patient with neck trauma has to master. At C5 level, the core muscles suffer quite often, and active turning is very complicated. To train this skill, a lot of time and efforts of the patient is required. He is now trying to train flexing the body and the hands and arms. Please note how many times he has already repeated, so his endurance level is quite good. And this is an example of exercise at home. He's controlling arms and shoulders using lumbar region as a stabilization. So that's a good controlled movement. All phases are present there: stability, mobility, and controlled mobility in shoulder joints. Once again, note the willpower of this patient. He decided for himself that he is not going to lie down. He's going to do his best to be able to do more. Balance. It's a very difficult exercise for a patient with neck injury. In spite of the fact that the surface of support is quite large, the patient manages to keep this balance for a long time. He actually managed to do it for 1.5 minutes. He is able to drink out of a cup himself, and a small part of an individual training. This is compensatory crawling. We are selecting the support point. He's concentrating. He's choosing the amplitude. Here there was a fall. When I suggested, when I offered the patient to raise him, he said, "No, I'll do it myself." In spite of the fact that that was not the beginning of the workout, and he was already tired a little bit. So he chose activity and autonomy, and also considered the psycho-emotional sphere. So he's showing to the camera that he is able and willing to continue. And he's also attempting here to crawl by flexing elbows. And here we can see some home rehabilitation, passive. They purchased such passive equipment, simulators for legs and arms, so he's exercising himself. Remember, an attempt of active balance without support. Here we can see some active and passive turns, Dad is helping him. The leg is put away a little bit to make the task more complex. And he's using here lateral muscles of facial chain. This is training of the wrist muscles. And at home they are also continuing to verticalize using this equipment. He's eating himself. He is holding the spoon. So we're basically following the table that we saw, and the table promised that the patient will never be able to do so. And here he's using a wheelchair with a medium level of neck. Thank you for your attention.
Спасибо.
Thank you for your work. Now I would like to invite the representative of the institute, Irene Ponina. She is a person who helps surgeons, neuro surgeons, and also in the area of rehabilitation. Irina, please, you're welcome. Dear colleagues, it was already said that at the early stages of this trauma, it's very important to compensate the status. But this trauma is linked with hypermetabolism. But when we speak about spinal injury, we should say that it has some very evident specialities. There are two things. When we speak about acute and beginning periods, so acute period and the period of recovery, these are 50%, that's not enough. But then there is this absence of moving activities. It leads to obesity, and then it can be accompanied by sarcopenic obesity already, even in so also diabetes mellitus. And in our practice, we pay a lot of attention to the support, nutrition support. Very often we have to restore needs, but our goal is to preserve muscles of our patients because they have neurological deficit of active muscle groups. And besides adequate nutrition support, we also need to rehabilitate them physically. We should increase their tolerance to physical activities. Speaking about nutrition support, we developed our own program how to compensate these ingredients, physical activities, if patients are stricken to bed. So, for example, the teenager is 14 years old. He got spinal injury in 3 months. So they are quite overweight. He says, I don't want to do anything. My mothers and my grandmother do everything for me, so I work with the computer and that's fine. But if we go to standard recommendations regarding such heavy injuries, serious injuries, so rehabilitation is very important here. Why should we increase 1.5 times this nutrition support if patients don't do anything? That's why, first of all, we should evaluate his physical activity. When we speak about physical activity, we all know that we have international classification. Tolerance should, contain aerobic reserve, the degree of fatigue, and physical endurance, general physical endurance. All our children did not have problems with cardiovascular systems. When we researched our children, we can say that so they have a good level of cardiologic activities. We have performed ECG, and so this was good. Then next, aerobic reserve. If we speak about sports of high achievements, it's said there that it should be compliant with frequency of heart contractions, heart contraction rate. But we don't see this correlation between anaerobic threshold and frequency of heart contractions. That's why we use other things like load test. Then evaluation of tiredness, degree of tiredness. We have the scale of fatigue and also ergospirometry. We define breath conditions, even those patients who train too much and they did not follow our recommendations at home. Even they are not doing anything, their breath rate is increased because of these physical activities, because they trained too much. This is the standard threshold evaluations. Ergospirometric indicators. Here we have neurological deficits, limitations in muscles. Tolerance can be defined as very low, and when we build a program of physical activities, we should consider this. Now, please, Lvova Ekaterina. She's the medical psychologist, rehabilitation department, the Institute of Traumatology and Emergency Care. If we speak about doctors' gradation in this multidisciplinary team, psychologists play a pivotal role. They work with parents and kids, and it's very important that parents should help physicians and their children, and psychologists, of course, help this a lot. This is 90% of success to achieve good result. Good afternoon, dear colleagues. So I would like to describe the main psychological complications which we have. And I don't speak about the beginning of the trauma, the first 2-3 days, but we try to work with patients as early as possible. Of course, I will speak about patients of other periods when patients already understand, realize that they have trauma, that they have sustained traumas. We divided main psychological challenges and difficulties of children patients: loss of control and independency. So when trauma happens, kids could do everything, but after traumas they can't control his movements. He can't even control his sphincters. He is dependent on his mother and father. He even can't control his emotions. This leads to frustration. Very unpleasant feelings, emotions emerge, a feeling of helplessness and anger. This can lead to emotional
breakthroughs. We try to work with his relatives, and when patients have more possibilities, it's very important to delegate him responsibilities, to delegate him some functions, and also so also we would like to change social roles. Patients after severe traumas have different cognitive processes. Usually they now study at home. This is the restriction of their social activity. Usually our patients focus on physical activities, and this leads to change of social status, and sometimes it can be social deprivation. So also then they have the feelings of isolation, but here we help this. Marika also spoke about it, so that friends and peer contact is important. I have an example of our patient. Svetlana already spoke about it, and Vlad spoke about him. So we had the video about him. When this patient was in our department of neurosurgery, his friends from St. Petersburg came to him for his classmates. And it's not allowed even to let them go inside our building, but still, of course, we created all conditions for these classmates to come to him. It was great support for him. Also, we tried to find the new social roles for them. For example, future studies, and now he's already at the third course of the university in St. Petersburg. This boy. Also, Svetlana, with her colleagues, organizes meetings with Olympic champions at our institute. And speaking about Roma, again, he participates actively at the international. So at the international events, he plays rugby and even compete with other countries. Also, involvement of families in different events. We also have a lot of marathons, meetings, and the other problems. The other problem, this is imbalance of emotion. Of course, these people have frustration, desperation, anger, a lot of bad emotions, negative emotions, and here we also work with our colleagues, as psychiatrists, because we can't do without them here. And our main help, this is awareness of patients, his family, individual psychological supervision, help, and also 2 minutes about family. Family even has sometimes more stress that their children, the child has trauma, also feels this helplessness, especially when children are in intensive care department or in reanimation department. We have to help parents also at this stage. Then emotional crisis, because family also has to change their life. Because if a child has disabilities, becomes disabled, of course, here parents also have to change their lives. We try to optimize the mode of care, and in our practice we also use help of volunteers. What's happening to parents in a stress situation? They sometimes have some frustration, and we also work with parents quite actively. Thank you very much for your attention. Thank you, Ekaterina. Friends, we finished our main part. If you have questions, please ask the questions. We don't have a lot of time left, but maybe some kind of express questions. Do you have questions to our speakers? No questions. In this case, Marika and Svetlana, please briefly, could you comment on this session? What about your impressions? Maybe you can say a few words about Russia and about our today's event. And also about your plans for the future with us.
Yeah, I hope we can have more collaboration because, and I think that goes for every country that have with children with spinal cord injury, and I think it would be great if that we could do an international camp for maybe adolescents from different countries in the world to meet each other and so on. They have a lot to learn from each other, and I can also see that it's when many has passed, I mean, the frustration about the injury and so on, they can really have good lives, and I think they also are getting very strong persons, both physically and mentally, and have a lot to give to others too. And I'm very excited to be here, and I think it sounds very interesting to come in May to see the clinic and to meet all of you. And yeah, thank you.
I would like also to thank Marika. I have heard your presentation, and I already have something in mind. Speaking about these camps, we should also give it a go. We should try it. We have already an opportunity. We already know where to arrange such camps. We already know the location. We have the ideas. And of course, now at this session, we can't cover all the aspects because we have only 90 minutes. We have multidisciplinary teams, but they have some other specialists, ergotherapists, and physiotherapists, a lot of other specialists, many specialists. Sometimes we have a list of 40 different types of specialists, practically, who participate in this process. Transmagnet simulation, some other methods of simulation. The process is quite expensive, but still it's well worth doing. And when we can see the result, you can see the patients who really can cut the salad, but it was expected that he couldn't do anything. It's great. Thank you very much that you are present here. I will see you in May. Thank you very much. Well, friends, in conclusion, I would like to say that we are all people, and first of all, we are parents. Everybody has kids, and in any disease, irrespective of its type, traumas or something else, even not treatment is important, but prevention is important. As practice shows, the majority of traumas can be avoided, and parents are to blame, unfortunately, because we always are busy. But if you want your child to stay healthy and happy, spend less money on him, but spend more time to him. I wish you all health, happiness. See you. And I can see also now our members of our team, therapeutic department, but unfortunately we don't have time for them. If there are colleagues from other medical institutions, I can also say that this institute is open for the dialogue. You can always contact these people and get any help possible. Thank you very much for your attention. Goodbye.